name is Jill Berry Bowen, CEO of Northwestern Medical Center and your host of the NMC Health Beat Show, dedicated to discussing important healthcare topics of interest to our community. Today, I'm joined by Dr. Mark Foley, the Medical Director of NMC's Diagnostic Imaging Department, and with him is David Gervais, the manager of the department. And today we're going to be talking about tomosynthesis. I can't wait to hear more about that. But first, before we dive into that, let's talk about diagnostic imaging.
Sure.
And actually, it's transitioned from names. It used to be X-ray, right? And now it's evolved. So what does that all involve? Good morning. Thanks for joining me on this show.
Jill, our pleasure. So diagnostic imaging really has morphed, like you said, from the term radiology, which traditionally is the use of high energy ionizing radiation in order to produce radiographs. But because we use a lot of non-ionizing radiation now, like MRIs or ultrasound, the term diagnostic imaging is more all-encompassing and allows us to bring all of those subsections or modalities into an umbrella, like diagnostic imaging. So ultrasound and MRI and CAT scan, X-ray, they're all under there.
And there's a reason for all of those, right?
Absolutely.
Wow.
There's a reason for every test.
That's great. Thank you for giving that overview. So tomosynthesis, what actually is it?
So tomosynthesis is an advancement in mammography and breast imaging, where it takes a step up from 2D imaging, which is what conventional mammography was, to add in three-dimensional images.
So what is the difference? So it's an advancement of mammography, but when do you use one or the other?
So right now we use it in all cases if the patient chooses to undergo it at our NMC main campus. And what it is our conventional mammography are two images of each breast. One is a top-down view and the other is kind of side to side. With tomography, what we do is we take an additional three-dimensional image where the scanner goes in a short arc around the top and around the side, and that data set then gives us additional imaging, much like a CAT scan is for the abdomen.
Okay. So is this 3D mammography, is that now the standard for testing?
It's not the current standard as far as the federal regulations go for MQSA standards, which still maintains 2D mammography as the standard to which all hospitals must keep if they're allowed to do breast imaging. But in many hospitals across the country and in almost all hospitals in the state, 3D mammography is the addition to 2D mammography that allows us to image the breasts with more efficiency than before.
Okay. So if you're just having a routine mammogram, would you have it on the 2D and then advance to the tomosynthesis, or is there a progression? So
right now we're offering all patients who come for mammography the option of having 3D mammography. They will get the 2D images first, which is the standard, and then at the same time they'll get an additional set of images in the three-dimensional plane.
Okay.
And all patients are offered that.
Okay, so they do have a choice then.
We still offer two-dimensional mammograms in Georgia and on the NMC campus, but all patients are informed prior to getting their exam that they have that choice, that this is something new that we're offering, that, like Dr. Foley explained, it might not yet be the 100% standard, but it is an advancement in breast imaging that is leading to statistics which prove decreased callback times, things like that, which are beneficial to our patients.
Okay, great, great. So I was going to ask you about that. So the benefits of the 3D imaging, so maybe talk a little bit about that, the why behind this.
Okay. So what happens with two-dimensional mammography is that you're trying to pick up small, early subclinical breast cancers in breast tissue that may be very dense, in other words, can be very hard to see through. When we do the 2D images, we compress the breast down, which is why women feel uncomfortable, but it allows us to push that tissue out of the way to see if there's anything lying underneath. We don't get to push it all out of the way, so the 3D images allows us a few views on each side, which means that if something lines up, makes it look like something, the 3D images lets us kind of turn our heads a little bit, come around it, and it tells us if this is something we do need to do more investigation of, or if it's a an illusion created by the 2D images. So the one benefit is that we're more confident in saying there's nothing there.
Sure.
We can see her again in a year. But also you can start to pick up some very early changes such as architectural distortion, where there's no mass, there's no change, there's no obvious changes, but you can start to see a little bit of change in the natural makeup of the breast that will prompt us to do additional imaging. So the two main take-home points is it decreases our callback rate, and it can potentially increase our detection of breast cancers. And our experience to date so far is our breast cancers that we are seeing, we're seeing better with the 3D images.
Oh, wonderful. That's great. That's great. So when you actually perform the test, is it the same as if you were having the traditional mammography, or is there a difference for the experience for the woman having the test?
Right now, the woman's going to experience just a longer time scanning. So they'll have the single exposure beep, and then they'll also have the 3D beep where it goes beep, 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 beep. So they'll feel like they're in a scanner.
Okay.
For the portion, but and they'll be in compression for a little bit longer because we do the additional images. But that's the only difference that they'll feel. There's no pain associated with the extra images.
Okay.
There's no new positions that they have to go under.
Okay.
So it's just a brief extra period of time in the compression unit.
Okay.
About 7 to 10 seconds.
7 to 10 seconds? Okay. Because, when it's your time for your mammogram,
Right.
you think about these things, about how long, what's the difference here. It matters, so that's great, thank you. So I think you both have mentioned some statistics.
Sure.
Do you have anything, or is it too early?
No, I do. That was one of the biggest reasons we wanted to come on the show, is to show our community what this technology is doing for us. And I brought some stats with me that I'd like to share with you.
All right, let's take a look.
So one of the things that I want to show first is our number of callbacks by week since we started tracking this when Chelsea Mulherin, our breast care nurse navigator, started. What you see is a red line kind of right in the middle of the chart, and after that red line you'll see that those spikes and bumps really kind of narrow down. And what this is showing us, Jill, is that before tomosynthesis we had a callback rate that sometimes went as high as 25 patients per week needing to be called back for additional images. But by instituting this particular technology, we're able to narrow that down. We're seeing an average of now only 10 to 15 patients that need to be called back. And like Dr. Foley was saying earlier, there's an increased confidence in those folks that we say, okay, we don't need to call you back for additional images. That way, only the folks who really need to come back are truly coming back.
Wow.
There's another graph I wanted to share with you that's showing the impact of Chelsea Mulherin, who was on our show before. When the doctors and the radiologists read an exam and they're confident that the patient does need to be called back, we're now, since Chelsea started back in 2015, you can see a huge sharp increase in the number of patients that we're able to get a phone call out to in less than 2 days to let them know that we need you to come back in for your additional images. Chelsea is there to help them through the process, answer any questions they have. And so we're reaching patients a lot sooner than we ever were before.
And that's when they need the call back to have
That's
more
right.
more testing.
Yeah, and of course, getting called back, inevitably there's a
impressive.
lot of questions, right?
Yes.
And that's what Chelsea's role is, very important.
Great. That's awesome. Well, thank you for sharing that. That's
Thank you.
that's terrific, and it's reassuring to the woman to have the testing and knowing that they're not getting called back unnecessarily. It's really because of the clearer definition, I guess, in what you're seeing.
Yeah.
So that's really that's wonderful. So you mentioned Chelsea. We have talked with her before, but it was that one time. So can you talk about the mammography team and what that entails and who's on it? And
I'm going to let Dr. Foley address that. He's on the front line working with that team.
Our breast imaging team is kind of a little circle of the diagnostic imaging department, where it comprises our mammographers, the people who take the mammograms. We have our ultrasound team who scan the breasts under ultrasound if there's anything we need to clear up either on the mammography, or if a woman is feeling something, we may go straight to ultrasound with or without a mammogram. And then on the radiology side, there's myself and my two colleagues, Dr. Lopatina and Dr. Meyer, who will review the images. But then we also have Chelsea, who kind of ties it all in together. You know, she's kind of on the front line, linking all of our jobs together, presenting it in a way that, you know, there's a single face that the women can associate, know who they're seeing, know who they're talking to, and kind of get a condensed version of my language put into a language the patient can understand. And Chelsea has been absolutely fantastic in advancing our efficiency in the breast imaging section. You know, with her on board, we've been able to improve our the speed at which we can get women back in for biopsies if needed.
Nice.
You know, she also acts as the liaison with the primary care providers, so she spends a lot of time talking to them, getting the orders all squared away, calling women when it's time for their 6-month follow-ups, which we will sometimes do if we think something is okay, but we want to be sure and we don't want to wait a year. So behind the scenes, she's extremely busy getting all that taken care of. But we have noticed to translate. When I first came on board, when it came to recommending a biopsy, it would sometimes be a week or 2 weeks before we would get the women back. Now it's much, much shorter. Sometimes even on the same day we can get the biopsy taken care of.
Yeah, that's incredible. That takes a lot of anxiety, you know, away from the woman, so that's great to hear. You'd mentioned ultrasound. At what point is the ultrasound needed for breast care?
It depends on what the presentation is. If the woman is under 35, we will typically start with an ultrasound straight away.
Okay.
In other words, a woman will present under 35 because they feel something or their doctor feels something. And at that age, mammography is less sensitive, so we will go straight to ultrasound first.
Okay.
In other cases, when we call the women back from a mammography, we may do additional mammographic images and ultrasound, or we may go straight from the screening mammogram to an ultrasound. Those are the two main areas that we will use ultrasound. Sometimes we may see something on the original workup, and then we can follow the patient with an ultrasound in 6 and 12 months, again, to be sure everything is okay. What ultrasound also does is if we see anything under ultrasound, we use ultrasound for our biopsy technique.
Okay.
So we will do most of our biopsies now under ultrasound guidance.
Excellent, excellent. That's great. So how long does it take to get a mammogram? So if someone if it's due and it's time for their mammogram, and where can they get those?
Yeah, from the admin point of view, we can do sometimes same day, next day scheduling if you want.
Okay.
Of course, if a patient is choosing to have a 2-dimensional mammogram, we still have walk-in capabilities down at Georgia Urgent Care.
Okay.
So those
Good.
are always
Good to know.
available. And again, patients are always informed of that 3D availability. And I know that our mammogram schedule lately certainly has at least one spot where we can throw somebody in, say they walk into the hospital.
Excellent. Good.
Yeah.
Good. So it can be very timely.
It can be,
It
absolutely.
really sounds like you've taken a lot of kind of time out of the whole process from the start to finish. If they need extra testing or biopsy, it sounds like it's really more efficient for the woman.
Yep, and you know, Chelsea and the radiologist team, they've looked at the process, they're streamlining it. It's still a work in progress. We're doing our best to take out as much extraneous time as we can.
Yeah.
Inevitably, there's constraints on personnel, equipment, and you know, radiologist time. So that all factors into where we're at right now, but we're at a good spot and we're very happy with where we are right now.
Great, thank you. Well, thank you for all your work on this to really streamline the process, and I know the women out there are thanking you for this process. So before we finish, because time flies when we're having so much fun with this type of conversation, it's exciting. Dr. Foley, you haven't been in Vermont very long, so how's Vermont treating you?
So I came here in 2014 after completing all of my training, and it's been very pleasant. I grew up in a community much the same size as this back in Ireland, but what struck me for a community of the same size, just how we did not have a hospital period in the town I grew up in. You had to go to the big city for anything, and to have a facility like NMC servicing the community is amazing. I mean, the amount of high-level intensive medical interventions and treatments that we can provide here at a local level is amazing. And in the 2 years I've been here, we've already seen massive changes in not just in our breast imaging section, but also, you know, we're getting ready to bring out our low-dose lung cancer screening for CAT scans, which is a work in progress, but will be up and running soon, we hope. But you know, in the time I've been here, I've seen many changes, and they've all been for the better. Excellent,
excellent. Well, it's great having you here, so thank you for being part of our team. And David, thanks for being back on the show. It's great, it's always informative, because diagnostic imaging, is expanding, and we do have the latest technology, and I think some folks may not realize that, so that's terrific. So thanks for joining the show.
Thank you.
Thank you.
And I'm Jill Berry Bowen, the CEO of Northwestern Medical Center, and it's been wonderful talking about tomosynthesis, and it's just a reminder to women to make sure you get your mammograms. It is so important for your health. Thank you.